Hello. Let's learn about how to interpret antimicrobial susceptibility reports. Let us understand why antimicrobial susceptibility testing is required. It is required for selection of appropriate antibiotic, then monitoring the development of resistance, then detect new resistance mechanisms, then compare trends of antibiogram among different geographical areas and healthcare settings, and develop and evaluate the interventions and preventive strategies. What is the importance of appropriate sampling? Say for blood samples, the blood samples needs to be the appropriate collection, storage, and transport guidelines needs to be followed. For blood sample, ideally paired culture bottles needs to be collected. That is one Arabic and anaerobic water from one hand and one anaerobic and anaerobic water from other hands. It should not be refrigerated and it should be transported immediately within 2 hours of collection to the laboratory. Recommended the blood sample should be processed in the laboratory within 2 hours of collection. If CSF sample is needs to be collected for diagnosis of meningitis and other elements, and in fasciitis organisms like Neisseria meningitis is suspected to be the cause of illness, then a delay of several hours will affect treatment. In such cases, inoculate the sample, CSF sample, into pre-warmed chocolate agar plates and then incubate at 35 degrees Celsius in a 5% carbon dioxide atmosphere, so that we get the more chances of bacterial survival. Do not refrigerate the CSF sample. As soon as the CSF has been collected, it should be transported immediately to the microbiology laboratory. And the CSF sample needs to be processed within an hour of collection. So that was about the importance of appropriate sample. Now there are two different methods of sensitivity testing. One is phenotypic method and another is genotypic method. Phenotypic methods are universally applicable, mechanism independent, and they have exact phenotypic categorization. They have therapeutic relevance too. However, the issue with phenotypic method is that it requires time for the culture growth. It is expression dependent. While genotypic methods, they are very rapid. Within an hour, they give the identification and the resistance gene identification. It confirms the resistance mechanism. However, the issue is that it negativity does not necessarily mean susceptibility. Positive does not necessarily confer phenotypic resistance, and it is limited to only few antibiotics. So, in phenotypic susceptibility testing is universal, and it is mostly it should be followed in most of the healthcare settings. How when whether now we will see the phenotypic testing methods in this session. What there are different methods of phenotypic testing, and the selection of the method may be based on numerous factors such as ease of performance, flexibility, adaptability, cost, reproducibility, reliability, accuracy, and preference. Only few methods have been shown to be reproducible and repeatable, and these are disk diffusion, broad dilution in each test. What does this sensitive testing methods provide? They provide qualitative results or quantitative results. Qualitative results indicate how a drug may respond in vivo, and they are resistant, intermediate, and sensitive results. Resistant means treatment failure can be expected. Intermediate means treatment is possible at higher doses. Sensitive means successful treatment is possible with the normal doses recommended. Quantity results are reported as MIC, that is minimum inhibitor concentration. Lowest antimicrobial concentration is required that will inhibit the growth or kill the test organism or a defined range. That is minimum inhibitor concentration. We have seen about phenotypic methods, disk diffusion, broad dilution, and e-test. Let's see what is disk diffusion. In disk diffusion, antibiotic over a culture plate, the bacterial suspension is inoculated over a culture plate, and after the overnight incubation, when we get the colonies, a long colonies of the bacterial colonies on the culture plate, over that plate, antibiotic discs, which are 6 antibiotic impregnated paper discs, they are then inoculated over these culture plates. And after overnight incubation of this culture plate with the impregnated antibiotic discs, inoculated antibiotic discs, they are then observed after an overnight incubation for the zones of clearing with a scale. And based on the zone of clearing, that is zone of inhibition, the antibiotic is classified either as or interpreted either as sensitive, intermediate, or resistant. So that's about this diffusion method. The MIC method is the lowest concentration of the drug that inhibits the growth of the bacteria. In MIC method, we consider wells, the numerous wells, and on these wells, the increasing concentration of antibiotics are added. And over these wells, then back inoculated, and it is then interpreted after overnight incubation. And the wells that show no growth or clear is taken as the MIC. As you can see from this picture, the wells with 0.06 antibiotic concentration and 0.12 antibiotic concentration and 0.5 antibiotic concentration are with bacterial growth. However, the wells with a antibiotic concentration 1 and 2 are clear. So the 1 is taken as the MIC. The lowest well that shows no growth is taken as the MIC. That is the lowest concentration of antibiotic that prevents turbidity is considered to be the MIC. That was about MIC. Next is epsilon test or heat test. This is again a combination of disk diffusion and broad dilution. It applies both their principles and gives MIC values. Wherein there is a paper disc impregnated with the antibiotic, but it also consists of the antibiotic concentration labeled on this paper disc, and it is then similar to this diffusion. It is inoculated onto the culture plate with the bacterial suspension. After the overnight incubation, it is then observed for the clear zone, and the point where the clear zone is interrupted is taken as the MIC. Other method of doing phenotypic testing is the automated microbiology methods, wherein we have Vitek and Phoenix and others. They're advanced methods. They're completely automated. Broad microorganism is again the principle of these machines. It also identifies the bacteria as well provides the sensory testings. To summarize, there are disk diffusion, MIC, broad dilution, and heat test and automated methods. For disk diffusion, it provides qualitative results. Antibiotic discs are used. The zone of clearing or the antibiotics is taken as the criteria to interpret it. However, it has less reproducible data. The gold standard is MIC, that is broad dilution. It provides quantitative results, and the inhibitor concentration is taken as the interpretive criteria. Heat test is a combination of disk diffusion and broad dilution. It is easy to perform, especially in low resource settings. It gives MIC values. Automated methods is used for both identification as well as sensitivity. The advantage of the automated method is that we get a real-time antibiogram too. Both that all through either pathogen or sample or department-wise. It provides automated advanced method of MICs, and broad dilution is the principles. It is quicker and provides detailed antibiogram. Now, how to interpret the results? Will the physician understand the results? Will the physician appropriately modify the antimicrobials based on the results? Will the physician act promptly on the results? Both diagnostic and antimicrobial stewardship are required to optimize the use of resources and outcomes. So the role of the clinical microbiologist is very key in this diagnostic stewardship. The right diagnostic stewardship means right test for the right patient at the right time. Antimicrobial stewardship is right interpretation, right antimicrobial and right time. So there needs to be good, strong correlation, interaction between the microbiologist and the healthcare provider for optimal diagnostic stewardship strategies. The main concept is the clinical categorization of the MICs, either as susceptible, intermediate, or resistant. So it depends all upon breakpoints. When the MIC is less than the breakpoint, it is interpreted as intermediate or sensitive. If the MIC is greater than the breakpoint, it is interpreted as resistant. Breakpoints are more important. While we report under microbiology results, the breakpoint needs to be supplemented for the clinicians to interpret the results. So based on breakpoints, the MIC is input as susceptible, intermediate, resistant. For susceptible, it means the patient organism will respond to the therapy with the normal dosage. Resistance means it won't respond to the normal dosage antibiotic. Intermediate response is likely, but less likely than the sensitive strain. So breakpoint are the concentration or the discriminatory cutoffs used in the interpretation of the MICs, and these breakpoints are given by FDA, CLSI, and UCAST. Now, how these breakpoints are? The breakpoints are derived from serum achievable levels for each antimicrobial agents from a particular resistance mechanism and successful therapeutic outcomes. In practical situation, it is not the entire range of the MICs may not be used for decision making, and therefore breakpoints is required to interpret the MICs as sensitive, intermediate, or resistant. These breakpoints are given by organizations like CLSI and UCAST. CLSI stands for Clinical and Laboratory Standard Institute, while UCAST stands for the European Committee on Antimicrobial Susceptibility Testing. So the CLSI guidelines are available free on the Wonder portal. UCAST guidelines are available free on the portal, while CLSI is available only for sale. Meetings of CLSI take place 2 years. UCAST takes place every 5 years. CLSI guidelines are recognized by FDA, but FDA still determines their own breakpoints, and UCAST functions as a breakpoint committee for European Medicines Agency. So we have numerous supplements available from the CLSI portal. How to do the sensory testings, what are the performance standards, and other such. Similarly, for the UCAST, we have the similar guidelines on the UCAST portal. Understanding of breakpoints is very important. Is key to for while interpreting the sensitive testings. Breakpoints are derived from three steps. First, the epidemiology cutoff are derived. Then the pharmacokinetics and pharmacodynamics indexes are applied to the CECOF, and then based on clinical considerations and studies, the breakpoints are derived from these values. There is also one criteria called a susceptible dose dependent or susceptible increased exposure. SDT is using CLSI, while SIC is using UCAS guidelines. Here, sometimes here it means that sometimes the antibiotics can still be used, but higher doses will be required. So this is the CLSI chart that is used. Say for example, for this organism Enterobacter, say if the MSC of CLSI is about 6, it is less than the if it comes between intermediate and resistant breakpoint, then it will be interpreted as intermediate. If the MSC would have been 12, it would have been interpreted as resistant. If the MSC would have been 1, it would have been interpreted as sensitive. So it is all based on the breakpoints that the MSC is interpreted as sensitive, intermediate, or resistant. Also, it is not possible for each antibody to be reported on the microbiology report. So, the results are extrapolated to other antibodies. For example, cephalexin predicts susceptibility to all the first generation cephalosporins. Erythromycin predicts susceptibility to azithromycin and clarithromycin. So, instead of reporting all the antibodies, one is erythromycin is reported in the microbiology report. Instead of reporting all the first generation cephalosporins, one is cephalexin is reported. So, that is called extrapolating the antimicrobial sensitivity. Also, it needs to be borne in mind that some organisms have natural or intrinsic resistance against some antibiotics. For example, enterococci, a common acquired hospital-acquired pathogen, is resistant to aminoglycoside, cephalosporins, and lincomansides on a natural basis, and these are the commonly prescribed empirical antibiotics. So this is a serious concern. Then to prevent the resistance, needs to prevent the enterococci infections. That's all from this session. We'll see in details about how to interpret sensitivity in our next session. Thank you.